You meet some unusual characters when you're on the lecture circuit, and there's a key opinion leader, Koen de Boel. If you've met him, he's from Belgium. He's a good friend of mine. He's about 6'3", 6'4". He used to weigh probably quite a bit, but now he's slimmer than I am. It's unbelievable. And he has this big head of blondish hair that he sits up with over here. And he's a very, very unusual character in the respect that his humor is a little bit left center. Mine's way right, but his is left. Oh. And what he does is after he finishes, and he loves to do lips, after he finishes doing lips, he always looks at the patient on stage. On stage, he looks at the patient and says, "Your lips are beautiful. What do you think?" The patient says, "Wow." And he says, "But we have to test them out." And he gives the patient a light kiss on the lips. Every case. So what did I do when I was organizing the meeting? Come on, guys. I got him a male patient. And he finished doing the male patient, and I said to him, Do you meet these unusual characters? But they're very funny. So Alexis, how are you?
Fine, thank you.
Let's think of something that we haven't done that we can do on you, at least so they can see. And then, oh, I know what I'm going to do with you. We're going to start off doing, in an unusual order, but we'll cover mostly everything. What I'd like to do, really, give me a big smile. Beautiful. Yeah. And you have a little bit of extra teeth showing. You see that your grin is a little bit wide? Let's see if we can temper that down a little bit. Would you like to do that?
Yes.
Okay. So what we're going to do is, here's your little pillow. You can sit back. I'm going to take, let me think. I'm trying to think of the products that you guys have here in the States that I can use over here. I'm going to use Ultra. You only have Ultra Plus? Okay. Then it might be a little, let me see your smile. Oh, no, it's okay. You know what? You're going to take the Ultra Plus and you're going to blend it down for me so I'll get close to what I want in the texture of it for Ultra. And give me a 1 to 2 blend. Or give me, so for the 1 cc over here, put in a half a cc, okay? With just a little teeny bit of epi. We're going to take a look at how we can redo this area over here. So let me just talk through, the people keep asking me about blended, when you put in, I don't know how to say this any better than don't listen to me. I do these types of things because what I started doing with upper lip barcode was I was using cannulas to subsize underneath. Kent and I were doing this. We started doing this with 27 or 30 gauge. I'm using mostly 27, 25 gauge now to do this, to release the fibrous bands between the lip, dermis, and the underlying muscle. And at the same time, putting in a little bit of filler that you want to be a smooth filler that will spread and have the mobility that she'll be able to smile without it being too stiff. So if I was using Resti, I would wet it down. I would use Ultra. It's probably pretty close to what I would use. We have other products up. I use Volbella, which you guys just got, okay, which is a nice product. So I'm going to take Ultra Plus and make it a little bit softer by giving it a little bit of the water that it wants and see if I can do that through a 27 gauge cannula. We're going to do that and we're going to coat. But listen to what happened. When I would do that is that after I finished doing the upper lip with the barcode, I would then take out my toxin, whether it was Botox or Dysport or whether it was Xeomin, and then I would inject into the subdermal region. Why? Because if you look at the orbicularis function of the muscle, it's really a two-functioning muscle. The pursing fibers are more superficial. The competence fibers are deeper. What keeps your lip against your teeth is the deeper stuff, and the pursing is the more superficial. If you go ahead and you treat the deeper ones, you can actually drop down the lip a little bit, which is great for a gummy show smile. And you got to ask this guy about gummy show because he's the king of gummy shows. So you can do that. But the patient will complain at about day 4 that they have trouble keeping the toothpaste in their mouth and it lasts for a day or two because you're not obliterating around the mouth, you're moderating. This is obliteration. This is moderation. Moderation means your brain will reset very quickly. And it will be able to function again within 2 or 3 days. So your injections are superficial over the lip over here, and I usually use a single unit or 2.5 or 2 units of Dysport, but a single unit of toxin, of Botox or Xeomin, that is into the dermis or just subdermal. And I said, but I'm putting it into the area that I just put in my filler. So that gave me the idea of mixing the two together. So people say, well, what is your What is your witch's brew? I don't have any answer for that. Just think about what you do. I know it usually takes me about 0.2 cc's to do upper lip with a filler on each side for the white part of the lip, what we call the ergotrid. And it takes me 4 units. So I drop a syringe that has 0.4 in it. She's looking and waiting for me. And then I add in my 4 units or my 10 units of Dysport. So I'm putting in the same quantities that I would normally use. The only thing I'm doing is putting it in one vehicle. Why am I seeing results at 19, 20, 22 months? I have now a series of patients that are close to 20 patients that I've done this on. It's close to 2 years now. Why am I seeing results so long? I don't know. Is the product, this is what we were talking about, is the toxin being slowly released? I don't think so. So what is happening? I'll tell you what I think is happening. This is my theory, but I don't know if it's true. We're releasing the skin from the muscle. We're then putting a spacer in and then telling the muscle, you stay calm, I don't want you pursing. And as we soften the contraction around the muscle, things start to heal. There's fibroplasia, there's collagenesis, and the skin will try to grab the muscle again. But guess what? There's a spacer in between, my filler, and it can't get it. So what does it do? It forms a layer of collagen, very similar to what we see in capsules of the breast. It forms a layer of collagen, very thin, underneath the dermis, and a second layer of collagen, and now you have a glide plane. And what you've done is you've reset the patient back to the way they were originally when things were gliding, and they weren't adherent, and they start to age forward from there. So the results have been surprising. It's usually an area of laser treatment. We understand that even in the best of hands, when Kent does it, he probably tells his patients, you're looking at about a 5 to 7 day downtime. Yeah. And he's the erbium king. He does beautiful work. But in a patient who hasn't got that, you don't get the same result. Don't get me wrong, because you're not changing the texture and tone of the skin, but you get a pretty decent result.
What's your Botox reconstituted there?
Oh, you're going to do it with that? Can we do that with you?
Whatever you want.
Oh, great. 1-to-1. What do you have here? Is this a 100 unit vial? Yeah. Mm-hmm. Because we have the 200s up north. So put in 1 cc of saline, please. I can do your neck too? Okay. So let's have some fun. Let's do some of that. Where else can you think of on her face?
I need a little bit of it.
See, where else can you think of on the face that the skin is very close to the muscle, almost directly opposed to it, is going to be in the crow's feet, here, and here in her. So people ask me, how do you do it? Maybe I'll just show you how I do it. I don't know whether it's the right way to do it or the wrong way to do it. Probably just got to get it there and let it do its work. I just have to be the bus that gets it there.
Comment on how many septi on the upper lip versus lower lip. We now notice them with cannulas, but not needles.
Right. So typically, women have more septi than men. In women, they have more septi when they're 60 plus. Not in her case, because she's 39, but in 60 plus patients, we have more septi, more on the upper lip than the lower lip. And in the actual red lip, we haven't done any lips, but you can open your mouth just a bit. Have you ever had injections done into your lips? You have. You have, I can see that.
But I want to show you. They want to make up your Botox, so what do you want?
So it's 1-to-1, 1 cc. Great. So what you're going to do is take out a little BD2. And you're going to draw up. Watch, I'll show them how to do this. We can take this out. Here's the BD2. You don't have a...
You want to pop top?
Pop top. Pop the top. I'll do it this way because I'm not going to use this needle anyways. So I'm drawing up right now, we have Botox over here. I'm drawing up 4 units, which is going to be, it's a 1-to-1 recon. So there it is. That's 4. You see that? Here, where's the 5? You guys can see it. There it is. I have my 0.4 in a 1 cc syringe. Do I? 0.4 of my blended Ultra Plus. You're going to give me a 1 cc syringe. You're going to put 0.4 in there because I'm going to use 0.2 per side. Okay? You good? Mm-hmm. I've never done this before, so I'm excited.
Oh, we got sidetracked about the septi.
Yeah. Oh, yeah. So they have these septi, and typically from the mucosa of the lip to the muscle, there's also septi over there. You've struggled sometimes on trying to do a lip enhancement, and you see the way the product bunches up, and it doesn't want to go through that septi, and they typically are located. Open your mouth. They're typically located right here over the lateral incisor in the middle. There's one, and there's one, and in the midline over here. And sometimes you get these patients that look like a duckbill. They sort of fill here and they don't fill here, and vice versa. The way to get rid of that, it's a very tough thing to do, If you keep on injecting from the side or you keep on injecting from above, you'll never be able to get that done, right? But if you have that little area that's right here, that's being tethered, that causes that little divot, you just fire your needle in right into it in a vertical plane from below. Just go submucosal with a small amount of product and put in the teeniest little bleb. You'll almost hear the thing go, and that's it. So you can't push the door open from either side, but you can get it by going from underneath there. You can actually open up the door frame. You want to hold this for me? What is this right now?
This is your Botox.
That is, huh? Good.
So also, when you're doing cannulas on the lip, on the white roll, for instance, you'll bump into these septi, and they're just like little speed bumps, just like they are with the ligaments on the face, just like the orbicularis ligament and the mandibular ligament. So those septi can be a little bit of an issue in some patients.
So here's our blended product. This is 1 to 2 blended on Ultra Plus. I pull it back a little bit. I just take up my toxin. And I fire it in on top of it. Now I'll take an empty syringe and the little Luer lock to Luer lock adapter.
Don't tell anybody he does this.
Please don't. You didn't hear it here. This is heresy. Okay? And
Mark, Dr.
Here we go.
Rubin's he's going to go back to Beverly Hills and say think we're crazy.
You are crazy. He knew it before. He knew I was crazy before, that's for sure.
How much did you blend the Ultra Plus?
1 to 2. Yeah, I'm not even sure if that's the right amount, but I think it feels pretty soft because I just want to be able to get it through. Look at that. It usually comes out quite milky. It's very nice. Is the Botox or is the toxin completely diffused throughout the whole thing? I don't know. But I know that I really don't.
Looks
I have no way, but it looks like it to me too. And I'm just getting the results. So give me a 27 gauge cannula, please.
You're a chef. I'd eat it.
You got the short 27? Beautiful. What it allows you to do, and the Trocar is a 27 Trocar cleanser, and we're ready to start. You ready? Yeah. You can do the exact same thing, but give me another 0.4, just like I did over here. And you saw the way I just added in the toxin?
Yeah.
27 gauge cannula. Use a 25 Trocar.
Yeah, but I want one with...
That's what I use. He uses a 27-27.
I want it with 10.
I'm not that good. I have to use the 25 Trocar.
We have the cleanser?
Yep.
Thank you. Can I have also the pad, please? You like giving me alcohol for cleansing. I'll take that chlorhexidine. So typically what I do is I'll make a little, if it's treating the barcode like it is on her, I'll pinch the skin up and I'll allow the skin to fall back into the needle. And I'll just spin it a little bit.
A little Watusi here.
There. How are you doing?
Ladies, do you want to take this, Deidre? Do you want to take this out?
What was that?
The little pop that you do to bring the skin down to the needle.
The little pop I do to bring the skin down to the needle scared you? Well,
no, I don't even feel it.
She doesn't even feel it. You're just being kind. It's the end of the day.
So exact angle of his trocar, and then as soon as he enters, he'll drop everything flat. So it's right parallel to where...
Now look at these little septi that you see over here. I'll put a little teeny bit of product in there because it has a little anesthetic in it as well. And I'll go as far as the filtral column. You don't want to transverse across the filtral column. First of all, there's a little artery over there. Second of all, there is a septum, which is great because it's going to protect my product. And you don't want to get rid of the divot. You don't want to get rid of that. You see where I am right now? This is between the skin and the muscle. You're feeling fine?
Yeah.
So it goes right to the GK point there.
That's it. And I start to slowly press on the plunger. And I'm supposed to put in about 0.2. Back and forth. Because this is subsizing at the same time that I'm putting in product. And I'm going to come up and do the entire ergotrid.
Ergotrid is the anatomy for the whole upper lip, above the vermilion from the nasolabial fold on each side. That ergotrid is that whole zone.
I've used 0.1 of product right now. I'm still coming across. So I'm doing subcision, laying in the product that's going to be the spacer that won't allow the skin to grab the dermis again.
Tiny bits of product.
And very, very small. I'm still at 0.1. I want to go up as high as 0.2.
Pretty well. Everybody that's over 50, we do this on. especially over 60.
Yeah, I find that over 60 miles an hour, it's a little tough. I'm just
Go
kidding.
ahead.
Do you have a trick for a horizontal line in the divot?
Do you? Do you have a trick for that?
Yeah.
Please tell me if you do. Maurizio puts in some product over here and causes a block that they can't actually elevate. There is no elevator of the lip over there. What you have happen is that the levator labii superioris liquid nasi pulls up like this and then causes a hammock over here. Kent, tell them what you do.
How I fix those, how I improve those
That's
is
the word.
lift up the nasolabial angle, because usually almost all those patients have a lowered angle, and you want to get that back to an obtuse, above 90 degrees. And then use the cannula just like this, a 27 gauge, usually a 1 inch length, 25 millimeter length, subdermal, and break up all those little septi with a tiny, tiny bits of Botox added to it, just like this. And break those up. I'm going right along the whole fold, horizontal, right with the fold, with that crease. Because it's a crease. It's not a line or a fold, it's a crease. It's like taking the hem down in your pants. So once you break those up, and I repeat that again when they come back for their regular visit in 4 months for their Botox. I repeat it again, usually twice, and they do very well. But one of the main tricks is lifting up the whole base of the nose there. And the third thing is, almost every one of those patients that's past 50 that has that, you need to do Arthur's trick of lifting the piriform fossa base up, across it like this. You lift that all up. And tuck your needle a bit underneath that line as well, and you lift that all up. So it's a combination of projection of that zone plus fixing the lines. So that's how I approach it.
Can you smile?
How many passes do you think you do for that 0.2cc?
Oh, God, I don't know, maybe 30, 50. I just keep doing it. And you know what you're doing? You're just doing it until you don't feel those septi popping as much anymore.
Yeah, you just break it up.
Yeah.
And don't really inject any filler until you're broke it up.
Now, I want to show you
Once broke it up,
something
then
that
you
it's
inject.
not a result of the toxin, but I want to show you something, if we can, on profile, is the fact that when you fill this area over here, and remember, she has silicone in her lips, so I was staying away from it. My usual last part of injection is right along the vermilion as I'm withdrawing, but I was a little nervous to go all the way down there because there's foreign body, similar to what somebody was asking before about injecting on top of it. But look at the pout that's created on her lip now. And that's what Greg Goodman from Australia showed me, is the fact that if you put in a little bit of filler into the upper lip and stiffen it, it does this. It gives them a little more of the Paris pout. So that's why I only use 0.2. If you use more of that, they're going to start to look like a duck.
Can you go back into the radial lines and inject just the radial lines themselves?
Absolutely. And that I do with a very wetted product, 50-50. I chase some of those lines in a vertical fashion with the BD2. It's exactly what you do. You polish it up. It was actually on my video, but I didn't get a chance to show all that. I don't know if you can appreciate it, but I can see it from here that she hasn't got anywhere near the amount of lines here now because I've released things. The question is, I don't want it to grab back down again, which if I use the combination. I started using combination way back when I was trying to get longer duration on lip augmentations in young patients. Patients who came in who were in their 20s, I would fill their lip with either Ultra or Restylane, depending what product I was using. Not give them a sausage lip, but try to define it. And then I would treat them, even though they didn't have lines of their upper lip, I would treat them with toxin because I didn't want there to be the shear effect, similar to what we do with chins. And I saw that I was getting results in lips that were lasting between 9 months to a year instead of the 6 months that I was struggling with. So I've always used that combination, but now I find that for the white part of the lip, it's really amazing. And we're going to do the same thing.
Generally, you don't have to go back and treat those little lines that are vertical lines, those little barcode lines with this, because you break them all up. And don't inject. If you watch, he wasn't injecting until after he broke those all up. And in Western Canada, we call it fracking, which is breaking up shale structure for the oil and gas kind of thing.
That's right.
So you frack these, break them all up, then you inject your products.
Yeah,
same way you do with forehead lines, creases on the side of the face. So you break up the products. And see how he's dropping down his hand after? So he drops it right, the plane down, and really gentle. It's exaggerated feel, patients, but most patients don't feel that much. It's annoying and distracting, but it's not that.
You just warn them about it because they don't like the
Yeah.
sensation of something crawling under the skin. But if I was to tell you
Pretty
0 is no
slow.
pain and 10 is horrific, what kind of pain are you having here? 1.
Yeah,
maybe.
1.
So we call that minimal discomfort. We don't call it painless.
So are you starting to inject now a little bit?
Yes.
Yeah,
And you can see.
antegrade, retrograde. Once you break it up and it's smooth, you don't feel any of those little grapefruit section septi.
Yeah.
Then you can start injecting. What was the question? Sorry.
I feel it a little bit more in the calf now.
Yes.
Any other place at all that you mix Botox with your HA?
Yeah, I'm going to show you. We're going to do it everywhere on her.
Yeah, lots.
Do you use this for mixing as well? I do. How do you reconstitute it? I reconstitute it with the same type of thing so I don't get confused. We get Dysport in 300 unit vials, and I reconstitute with 1.2 cc's. 1.2 cc's in a 300 unit vial is the same as 1 cc of saline in 100 unit of toxin of Botox. It's the same, so that every little minim is, instead of being 1 unit, is 2.5. So I do a 2.5 to 1 conversion, but I hate to convert one to the other because they're different products. They just don't act the same.
And you're not worried about her angular artery retention?
I'll worry about it, but I'm so far above it. I'm subdermal. I'm really subdermal, and
You're
and I'm really
not even close
yeah.
to the anatomy there.
Yeah,
That's-
and this
that's
would still be
fine.
called actually the facial artery. The angular artery really starts at the base of the
Up
nose.
higher.
It starts over here. In a lot of cases, it doesn't even connect. It's really weird. But yeah, that's what you got to worry about. But that's why I'm staying. You can almost see. I mean, if her skin was thinner, you'd almost see the color of my cannula. You notice that I'm not forcing the cannula. I'm feeling little pops, but I'm not forcing it. I just don't like to push cannulas where they don't want to go. If a little twirl or twist won't take it there, it means you're in the wrong plane. If it's bothering her, it's in the muscle, she's going to tell you. If you're in the dermis, which would be really impossible with a 27 gauge, it would really hurt like crazy, she would tell you as well. But she looks almost too comfortable. It's because of my talk aesthesia. I haven't shut up.
What was the name of what you call the area above the lip?
Ergotrid.
Ergotrid.
Ergotrid. Ergotrid. It's an old-fashioned name that's in the literature way back. You look it up on Google, you'll see that it's the whole upper lip from the nasolabial fold across above the vermilion, including the filtral column base there. So that's just the name for that whole zone. So he's essentially treating that whole ergotrid. It's an old-fashioned name. It's been in the literature for years. We just don't. It's not a common name in.
And we're old-fashioned guys, so we just
it's
refer
not
to
a
it.
common name in America, but it's in all the literature. So if you look it up, you'll just go to Google Images and ergotrid, and you'll see it.
Now, if I wanted to inject her lip to give her some enhancement of her lip, I could do it through the same access point over here. She has silicone in there, but I'm not. Look at the way she's flipping her lip out. I haven't touched her lip yet, but she's flipping her lip out. You can see it on the.
It's not bad. It's just it's nice.
It's nice. Yeah.
No, it looks good. I caught it.
Oh, you're cheating, are you? You're looking in the monitor.
You're looking in the monitor. Here we go. Thank you.
That's good.
Can I have what I asked you for before? What have you got? You got
Would you like on it?
27 gauge cannula again.
I have put Jupiter in my lap, Susan.
Okay. I find you're going to let me know what you think of this upper lip, which now I cannot see a single line on it, just about. Okay. And she's flipped out a little bit.
I'm sure my profile is much better. It's not flat.
No, it's not flat. She had a flat upper lip that she was complaining about, but now she's got a nice little upturn to that lip. And that's not injecting the vermilion. It's injecting above the vermilion. I do the same thing when I do lower faces. When I do lower faces, I put in product deep, intermediate, superficial. I use 3 little boluses over here. The reason I do that is I want something on bone to be supportive. I don't have to go deep here because the mandible is curved. You're going to waste a lot of product. I go into the sub-Q. And here I don't want to go deep because the labial artery is deep. And also I don't want to put product on teeth. So I go subdermal. And I've developed 3 pillars that are projecting the skin out and giving her support. You'll see the lower lip start to lift. But the problem is the upper lip, in most cases, in her case, it's actually turning up now. It's nice. But in most cases, they break over here. That little Knowlish triangle, we call it, because Noel Solish is the one that described it way back when. That female upper lateral lip triangle. And what I do is that after I'm doing all this stuff, I'll run a little product just above the vermilion border, just under the dermis over here, so that both of them go up with the turn. And if you were to ask me when I stop, it's when the patient reaches neutral in a mature patient or when they have a slight smile in a younger patient. Because it makes sense. If you're young and you're walking down the street and you have a smile on your face all the time, you should. You have nothing to worry about. But if you're my wife walking down the street, married to somebody like me that has all these other hassles with her children, who I don't know if they're still here, right? If you have that type of situation, she shouldn't be smiling all the time. She should be smiling responsively, so I leave it at a neutral position. That's the way I think when I'm doing commissures of the mouth. Now what we're going to do is we're going to... You don't mind if yours turn up a little bit? It makes you more youthful?
No,
they are turned up right now, actually.
Not careful, look like the Joker.
No, I don't want them turned up that much.
This is stuff. You got to leave it in... Yeah, I know. That's why you got to leave it in the thing and I'll pull it out. Okay? Thanks. Okay. So big smile now. So remember I told you, this is a combination of muscle overpowering the skin. We can put in toxin to soften the muscle, and that's what we normally do. But why not put in filler to toughen the skin? So you take off the 1 or 2 guys from the tug of war that are pulling too hard, and you add 1 or 2 guys in. You don't have to use as much product, perhaps. So let me ask you, what would you normally use in this area? If I was to ask you in toxin, if you were using Ano or Inca, what would it be? I mean, Botox or Xeomin. 12 units, what you'd use. Average. Okay, 12, maybe 25 of Dysport. Right? I have a little less. I have 10. And I have 10, right?
Yes.
Loaded into 0.4 over here. So I'm going to give her a small stick. I'm going to turn her head a little bit to the side. We're going to spin this. I hope I did that in a good place. I didn't measure her. Yeah, she's going to be fine. We're going to pull that out. I'm going to come back in at the same angle if I can find the hole, and then change my angle of approach. I'm going to put a little
When
pressure.
you're starting this, measure at first so you know exactly.
That's what I forgot
where
to
you
do,
want
but
go.
we're lucky that...
No, but your eye already told you where to go.
You're going to be so fine, my dear. Now, because I'm using a 27 gauge, the stuff is going to fly out very easily, so you got to be very light-handed. You'll see that the plunger is down in the bottom of my hand. And I'm trying to find the plane over here. There it goes, little pop, that I can get up there without it hurting her. That look how superficial I am. I'm really subdermal and over the vessels, because there's a ton of vessels over there. And I'm gently putting in product here, back and forth. See that? And I can feel the septi popping too. Are you comfortable? You're okay?
I hardly feel it.
You hardly feel it.
That one, but
Okay, good.
once in a while.
Once in a while?
He's not injecting any product yet.
Now I'm going to start it.
I'm going to start after you break out. She doesn't have many. There's not many septi here. If you get closer to the orbit, if he's a little deeper, you'd hit the orbicularis retaining ligament. But he's too shallow for that. This is an outstanding little trick. For patients that come in, this age group that says Botox no longer works for my crow's feet, look at my crow's feet. I still got crow's feet, and I had Botox last 2 weeks ago. So it's just that the lines now are they're there as a non-animation line. So this is outstanding concept. But it takes a little while for it to really work well. You have to have 2 or 3 of these done, and then it's fairly straightforward. It stays pretty good.
This is blended Ultra Plus. I'm still using the same product on her, but I could have used Resty over here.
And I don't think that's not bothering you too much, is it, dear?
No.
Yeah, usually it looks a lot worse than it actually is. Most patients hardly feel this at all, especially with a little talk anesthesia and some distraction.
Boy, you don't want to know that because
No, I haven't been using both.
she hasn't been using it, but I'm betting you, and we'll ask her, maybe next year when she comes back, she'll have had none done and she'll still have the result. Sorry, guys.
Botox makes me look tired.
No, you're going to get more and more patients that you're going to stay in business because people are going to... You know what happened when I started doing toxin into the upper lip in younger patients? They started talking. They said, why don't you go see Swift? My stuff seems to last longer than yours. Yours is out after 6 months. Almost a year, I still have my result. So You get more and more patients. The more and more patients that you get, the more areas that you can treat because you're being economic with the product, better the results.
What would you charge for something like this?
I would charge her firstborn.
Yeah. You don't want that one.
No, you don't want that one.
I don't want that one?
I didn't even ask her. I know that.
I don't know. What do you think you should charge? It's whatever. It's not what the product is. Patients don't come in and say, give me 1.2 cc's. What they do is they say, get rid of my crow's feet or make me look better over here. So what do you think it's worth? When I do a nose, that's the biggest markup. I usually charge somewhere between $600 and $700 to do a nose, but my product amount that I use, like I used on the first patient we did over here, is maybe 0.3 cc's of product. That's a huge markup. But you think you're ripping the patient off? They're happy as hell. They're paying for the hand, not for the injection. They're not paying for the paint. They're paying for the painter. You're spending time here to share ideas with us and talk about the things that we do. That's worth something. Don't undercut yourself.
Do you have like a breakdown price list of how you charge in each area, or you just discuss it with each patient individually?
I kind of discussed it with each patient, but I don't do the discussion because my wife won't let me. She's smart. She knows that I would do everything for free on everybody if I could. I just have too much fun doing this, and I'm a sucker for a story. So patients come in and say, oh, you know, my husband's thinking, I think he has a younger girlfriend, and my son, I don't know, I think he's on drugs. I end up injecting them for nothing. I just feel so bad. So I'm a real sucker. So she says, you know what, you just do the injections. We'll handle the cost and everything. But my receptionist, my secretary, my surgical coordinator is very good about that. I'm just going very slowly here and just showing you basically the technique.
How do you write this on a super bill? What do you put?
Can you give me a smile?
Eye job? What do you put?
Atta girl. Relax now. Beautiful. Sorry?
What do you put on the super bill when you give it to the patient? Is that a nose job, an eye job, or how does this?
No, you.
Oh, what do you put on the invoice, you mean? I don't put the amount of product. I just do aesthetic treatment or whatever, just whatever it is.
Just list the products.
Just list the product, but I don't give the
So
amount.
if you use Dysport or Xeomin or whatever you use, you just charge it. You don't give the amount.
No, I don't put
You give
units.
the
Never do.
Botox, and you give Resty Silk or Voluma, and list exactly what the patient had, and then the bill at the bottom. That's how we do it.
Anywhere you feel comfortable. I'm using only a 20.
I actually often inject mine a little bit higher.
Yep.
Maybe a half inch higher a little bit, but measure it out. And
What you want to make sure.
As you know, you can have, with crow's feet are interesting because you can have, you know, a lot of our patients that think they've got crow's feet have hummingbird's feet or wren's feet or blackbird's feet, and then they get crow's feet, and they get raven's feet, and then they get eagle's feet, and they get buzzard's feet that go right to the ears. So if they got buzzard's feet, then you got to start back further. So it's every patient is a different.
For the other side.
It's a different syntax of events a little bit because sometimes those crow's feet go way up into the forehead, and you get those creases that are above the eyelid into the brow, those sleep line creases as well, and they connect with the crow's feet. Then those patients you do the same thing. So it depends on the scenario. That's why you have to be a chef, not a cook. And you go according to what the face actually tells you what it wants. It just sort of yells at you. Says, "This is what I need."
To my patients, you know, because they get treated and I don't.
Jealous of your patients. That's interesting.
When I'm making them look beautiful, you know.
Yeah.
I'm jealous because I'm not in the chair.
Speed of injection over there was about 1/4 of what I do in my office. I was just being very slow and delicate because I didn't want her to say ouch or whatever the story was, and we were discussing and talking, and I'm a male, so I can't multitask as well as the females can. But I mean, the smoothness that you get on that cheek is just awesome. Okay?
Say you correct her with filler one visit, and say 4 months later she comes back for her standard Botox. Would you still retreat that eye with Botox?
Yeah, if she has significant movement, I would.
Yeah.
I would for sure. Right.
You just kind of go literally.
And you know what? It might not last a year. It might last 6 months or 7 months. But what you're going to notice is the fact that her static lines are going to be improved. And that's the kicker. Because she had some pretty intense static lines on this side. You see those? And now look at this. Okay, so the static lines are improved.
And they'll just get better and better.
They do. They improve with time. The result, the patient comes back in the upper lip. I said, oh, it's a pretty decent result when I finished. The patient came back after a month. I said, it's not bad. It's hanging in there. She says, I'm pretty happy with it. When she came back at 6 months, she said, what's going on? It's even better now. All your subcision is probably causing some collagenesis, I would think, right?
Exactly.
When you're in that location, you have to be pretty careful not to go too low so you don't get the zygomaticus.
It's pretty deep, number one, and you can touch off the... Remember, there's a couple of things. You can hit the top of the zygomaticus muscle, and you can actually take care of... You know, a lot of times when we do crow's feet treatment with just toxin, you leave those lines going down into the cheek, and they look smooth here, and then they have those lines there. That's a lot of times is your zygomaticus. And every now and then I will put a little bit of product, maybe 1 or 2 units, very deep down over there to catch the upper zygomaticus, but it's also the one that's lifting the mouth. So you got to be careful. The other thing that we have to realize, and we must realize, is the fact that the orbicularis is there to go ahead and to cause that purse string effect, but it's also an elevator of the cheek. And if you numb out the orbicularis completely, patients get what they call a non-Duchenne smile. The Duchenne smile is a very sincere smile. When you smile, you should have some lines in your face. It says sincere. When you do this, you're smiling. I like you. When you do this, it's like, get out of my face.
A Duchenne smile, you smile with, it's a spontaneous smile with your eyes. So now we've created a whole population of movie stars that have no eye smile. So the Duchenne smile is what we like. But your point about the zygomaticus major is a good one.
It is an excellent point.
That's why you saw him going a little bit above that.
Little bits of stuff.
So that's one of the reasons I go a little higher and try to stay away from that. Because otherwise, when you watch her animate, you can tell if she's using that zygomaticus major to smile. Otherwise, you get that shelf across here. And yeah, so no, it's a very good point to stay away from that. We avoid in this age group the zygomaticus major.
You're listening to him, huh? Yeah, I know, he's amazing. I can just listen to him also.
What's this?
So, where's my injection point over here? I don't care. It's wherever you feel comfortable. I'm right-handed. I'm going to go from above.
Yeah,
just to be different.
Yeah, right.
Just to be different, and maybe to show you that it really doesn't make a difference because we're using 27 or 25 gauge needles. If it's a patient that's a patient of color, a patient that has olive-colored skin, or maybe a patient that is a little bit darker, and you're worried about leaving a little dot of hyperpigmentation, so pick an old mole or pick something that you can go through, or maybe a little crow's foot or something that you can do it. But otherwise, I really don't mind too much.
And
see the way it's canted?
If you got a patient that's you're doing cannulas, and every time you do a little stick, they're not bleeding, always pick a little tiny landmark, a little prominent pore, a little lentigo or something you can pick so you can find that little trocar hole is another little trick.
You girls did a great blend over here for her. Thank you very much. What I'd like to do now is I'd like to get a little bit of Ultra blended because we're using Allergan on her. We're going to go with Ultra Plus. Perfect. Is it blended?
Because it'll affect your smile. I'd stay in here, but I wouldn't treat that line.
Okay, I want about a cc of product. I'm going to try something 1-to-1, please. Ultra Plus 1-to-1. The last thing I'm going to do on her is the thing that I wanted to show you.
There's no fat there.
Like you're going more medial now? Is that just an illusion?
He just changed.
Yeah, I'm just following the crows. I don't want to get into the orbicularis that's really underneath the bottom lid because I'll give her a little bit of a lid droop. But no, I think the other one I was kind of there. I'm trying to stay about the level of the lateral canthus. So here's my needle tip is here. My finger was here just to make sure I wasn't going too far. But thank you for warning me about that. Because, you know, it's great to demonstrate this stuff, but her effect is really only going to be in about 4 days or so. You know, that's the problem. I'm up north skiing. We actually got rid of our snow finally. Oh, yeah. Didn't we? Unless in Calgary you still have some. I don't know what the story is. And you'll feel the little pops, okay, every now and then.
They're all little septi.
There's a little septi, and then after I've popped through it and I've released it, like Ken says, then I start putting in the product. Sometimes I run the tiniest little bit, like a micro bit of product to take away the pain if the patient's complaining about it. Okay, I'm going to come down lower over here. There it goes. You can hear it, huh? You got to put
skiing through the trees.
Skiing through the trees. Is that what we're doing? A little waddling. I want to hit a tree. There we go. I'm mostly doing subcision. I'm keeping my product in the area where I would normally treat. And remember that I have here a total of 0.4 cc's of product, which is, what blend did we do? 1 to
10 units and 0.4 on each side.
Right. 0.4 of what product though? What was it?
Juvederm Ultra Plus.
1 to 2.
cc to 0.4.
Right. So this is the third blended down. It's 0.4. So I've really used, let's say 0.3 or 0.28, right? So it's 0.28 of product. Let's say a quarter of a cc of product and 10 units of toxin, or 25 of Dysport. And it's kind of boring, but I'm going nice and slow because I don't want to bruise her. Bruise him? How do what? Yeah, sure.
Her lateral canthus, medial canthus is fairly flat. You want it usually 5-10 degrees above the medial. If you look close at hers is actually pretty good. It's
Do we have another patient to inject after
fairly
this?
flat.
Do we have time? What time is it? 6 o'clock and you guys are still here?
Yeah. No,
Jeez.
we're going to be out of time. So her lateral canthus is fine, but you could, Dr. Swift could tell you how he would do a little bit under lateral canthus if you wanted to, but I think it's pretty tidy here. And she's got a fantastic snap on her lower lid. She's got a nice tone on her lower lid. I personally wouldn't treat it, but if it was hanging down a little bit at below, say 5-10 degrees below instead of 5 degrees above, I would lift it up. And I do it with silk with a mini and lift it up. And who actually taught us that years ago was Michael Caine, right?
Correct. We call it the Caine Triangle.
Yeah. Plastic surgeon, quirky plastic surgeon. And
quirky?
Yeah, he's real
Quirky about Michael.
Yeah. he's our friend, so we could call him quirky.
Any guy who goes from Juilliard into medicine, there's nothing quirky about him.
He's the smartest guy on the planet.
He is. He's just too smart. That's the problem.
Anyway, that's you just go.
He's in New York.
He's in New York. Yeah, you'd inject around this whole border here and just lift it up here a little bit. And you lift it up as you inject, so you give a support tissue in this whole little zone. So I'd probably use about 0.1, 0.15 max, Arthur?
Yes.
And I use straight up silk, straight up fine. We've used fine lines. It used to be called Touch in Europe and in Australia. They still call it Touch there now?
Yeah.
So it's just the same name. It's interesting that I think 60 plus countries have Botox as the same name, but all these fillers have different names, and it's confusing. But
the gel, please.
Yeah, just subdermal. Yeah, you can't show it because.
Okay, so in fact, let me take a look at her over here. She's look into the camera straight on. Okay, let me get my thing out of there. So she actually has a little bit of scleral show. You've had a blepharoplasty in the past, have you not?
She has.
Yeah, upper lower. And
she had a transcutaneous lower bleph.
Yeah.
When I was 44 and 45.
Really? Okay. So she's had a little bit of a bleph over here. She has a little bit. She's got not too bad a snap over
I
here.
have no fat pad.
Did you have a canthopexy too?
Pardon?
Did you have a canthopexy too?
Did they tighten up the corner at all?
I think they did.
I don't know. No.
Really?
Is there something flying around here, or am I seeing
I
that's
don't
something?
think he did.
Okay, so look straight into the camera, please, again. Okay. Look how much iris she's showing above her pupils. I kind of like that.
Yeah.
It's kind of like bedroom eyes almost to me. What are you doing later? You have a date? Okay. So anyways, let me see what we can do here. Let's look straight into the camera. And what the question is would it look a little better if we had this?
I have that shelf up there.
You have that shelf out there? Well, we've got to be careful about that. A little bit over here, maybe. Because she's not as lax. Well, not too bad. Give me a little bit. What do you have there?
A little bit of silk blended.
I wouldn't use silk. I'd use something with a little more robustness. This is
Juvederm Ultra Plus.
Plus. Okay, so give it to me. Put a little bit into a BD2. There's no toxin in there, though, is there?
No.
That's what you got to make sure of. Yeah. It looks really good on your cheeks. You're doing very well. Very nice. Look how smooth that is.
Yeah, it's nice.
It's nice. You like that?
Yeah.
It's what we call in Quebec a coup d'éclat. It's a little hit of life or vibrancy. Okay? Here we go. Let's have a little bit of that BD2. Let's have a little sponge, a little cleanser. I'm going to go right on the orbital rim over here. I'm going to do, just as Kent was talking about it, I'm going to do a little bit of product to give her into the Kane triangle over here. A little bit of injection.
And you can look this up in the literature. It's Dr. Michael Kane. It actually is written probably, oh my goodness, 15 years ago?
Oh yeah, at least.
15 years ago.
Okay, we're getting there. Good. Give me a little bit more, please.
You're right on the bone.
Right on the bone.
On the bone.
Here, I'm going to dull my needle to show you that I can't go any deeper.
And you're right on the rim.
I'm right on the rim, on the bone. I'm putting in product over here.
What sometimes I do is just lift a little bit off the bone, at the same time lift up the corner of the eye and inject. So this works as well.
So many veins in that area that you have to, when a patient comes in and I see that I have to do this, same thing like I do a tear trough sometimes, there's so many veins in the area that I always ask them, what are your social commitments over the next day or two? Because if you leave them with a bruise, they won't be happy. And a lot of times I'll reschedule a patient before a weekend or before the fact that they don't have anything. Because a lot of patients will come in and want this done because they have an affair that's coming up that night or the next night. I can't tell you, the worst experience I had was halfway through a facelift under local when the patient said, am I going to be bruised in 2 weeks when I get married? And I said, wasn't that something you should have mentioned to me before we actually had the surgery? And I was terrified that I was going to leave her bruises, that she was going to walk down the aisle looking weird. But she deserved it if she did anyway. So here's our first little bruise of the day, as I told you.
Very commonplace to have a...
Yeah. But it's a small little thing. I was on top of it right away. You can? Okay. Good. So while you're holding this, let me see a big smile, because we're going to look at that. And let's take a look what we have over here. She's showing the corners of her teeth in the back, okay? She's breaking.
That's a black hole.
Yeah. The black hole, as you call it, and she's breaking over here. Let's put this back down again. Let me have the stuff that we just prepared. Oh, I didn't bruise you too badly. Let's look into the camera.
It's a real tiny dot.
Look into the camera now. There. Okay, so you see how this eye looks a little bit straight, and this one has a little bit of an upturn. We'll do the same thing on the other side. It's ever so slight, but that's all you want, 5 to 10 degrees. Okay? It's done with the volume that you have over here. It just gives you a little bit, it's almost like a lateral canthopexy that we talk about. Here comes the last of the torture for today. 2 minutes and 45 seconds. Quick, we got to finish this. No, here we go.
How would you do those injections to open the eye up?
Injections to open the eye, because I was just asked about that.
Where's your pencil? Here, you can draw it in here.
So if I wanted to give her that eye that she has now, which is showing a lot of iris above the eye, then what I'm going to do is just here. You can come in a little bit closer with the camera. Thank you so much. Just above the outer side of the lashes, about 1 millimeter or so above the lashes, right here, sub-skin, just underneath the dermis over here, you put in a half a unit, maybe 1 unit at the most, but a half a unit. I found that 1 unit sometimes is too much. The other injection is the same area, but on the inside of the eye immediately, right here. Half a unit just under the skin, it makes a little teeny bleb. And then what will happen is the eye will open like this, it'll round out. So if you ever have a case of ptosis that you caused a slight 2 or 3 millimeter ptosis because you're using toxin and it got the elevator, that stuff works like a charm to go ahead and open the eye up again. Okay.
And then use, at the same time, use this half unit.
Yeah, he likes to open that up right there on the bottom. Yeah, he's gonna dot it and then show it. Yeah. And that will open the eye down this way.
This is the constrictor part of the orbicularis, and what you're working on. Constrictor part.
Is that 2 points or 1 point?
It was 2 points.
You
put 1 unit each?
1 unit.
You put 1 unit in each, Ken? Or a half unit?
Put a half unit.
Yeah.
Half unit in each one.
Smile for me. Big smile. Big breaking. Too much teeth showing. Let's see what we can do about that. Cleanser right here. Here we go. 1, 2, 3. Pop. Turn your head just a little bit.
Now, I probably do at least 8 or 9 patients every day with this technique right here, with these fixed lines. It's very quick and fast and easy, and it's, in fact, I've got 2 of my nurses that are probably better at it than I am now. They love it, and they're very good at it.
More. The blend on this is I'm using Ultra Plus and it's 1 to 2. Is that correct? 1 to 1 I asked for. That's right. I'd probably use it straight up. Yeah, maybe straight up or maybe just a slight little blend on it too.
I'd use a blend because she's pretty thin skinned here, and it might create some little bubbles here. So cross the lines. These are creases. These aren't lines. So you cross them, go up and down.
She's feathered. Look at all these. There we go.
Little septi bands here.
You're not hitting
And don't.
Lotus here, right?
I'm so far above it. It's amazing.
No, he's in subdermal.
I'm subdermal. I'm really like underneath. She's feeling it scraping along the bottom of her dermis. Are you okay with this?
Yeah, I don't.
No, you want to stay subdermal. They don't feel this much. You're not anywhere.
So this
near
is
muscle.
something that you're doing subdermal to give the skin more oomph so that when she smiles, the rhizorius can't pull it as much. Okay? It's not volume that we're putting in
It's
subcutaneously.
strut work
Strut work that we're doing. Exactly right. Watch. We'll see what we can do here. But she's really interesting in that she's quite thick. A little bit, but we're going to... Oh, Sculptra.
That's why. Now, in Sculptra patients...
Oh, my God. No wonder I'm struggling.
I was just going to ask you if she had Sculptra. Because that's how Sculptra behaves. Because they got that... It does its thing. You got all this fibrotic reaction, and you go to... It's like you're in a layer of cement.
Look at this.
Yeah. You bent his cannula.
Yeah, well, don't worry about it.
That's one of the reasons
I'm persistent.
you pursue exactly what that patient has had done, because you're going to come into these roadblocks. This isn't a speed bump. This is a roadblock.
Yeah. This here over here, there's always a little septi that's underneath, a little septum, a little tethering that's on the corner of the mouth, and I warn the patients you're going to feel a little pop. Okay?
It's not going to be dangerous.
Right,
it's just
pop right there.
annoying.
You felt it? And I'm coming across it right now. And I'm doing this over here. Wow, you're really tough. Look what you did to my cannula. Never see that. I use products that have a little bit of G prime that are a little bit stiff. Look, I can't even get this thing. And I'm going to have to change my cannula before I leave the cannula in her skin. This is going to look like an S when I take it out. Look at this. This is impressive, but that's okay. I like that. Okay. I can't even get into it.
I've had patients with Sculptra on this zone that you can't get the cannula through it at all.
See what you did to my instrument?
So remember this, because this will happen to you. It's not if, it's when. And you'll see patients and you just say, what the heck? And that's
Let me have a little bit of the arnica gel, please. I put in, how much did you give me, guys?
Probably 0.3. I would say about 0.3.
I used actually quite a bit.
Did you?
Yeah. It was 1 cc of a blend of 1 to 1. So it's a half cc of product, 0.5 cc of product. And I'm making sure that things layer out the way that I want them to over here. When you put your fingers on, sometimes like Kent says, he says it very well, it's either blend, mold, or massage. But what's so important is the proprioception in your fingers. You want to feel if there's a bump under the skin because the patient's going to touch their face as soon as they get home. And the second they touch their face, they feel something, you get the call at 8:30 or 9 o'clock at night. And they say, well, I feel something. But you feel it beforehand, you're going to be much better off. How are we doing? Smile.
We have a question from the audience. I was just curious about the modiolus there. Does this affect that at all?
No. Shouldn't really. The modiolus is the confluence of muscles that are coming just lateral to the orbicularis. The orbicularis is a muscle that doesn't have any attachments except to itself. And the modiolus, it's a sphincter muscle that's attached here. And a lot of the muscles are actually coming down into the modiolus over here. And I'm above it. To actually put product into the modiolus would really hurt because it's very fibrous. So it shouldn't have a problem, and I'm not using anything with toxin over here, so we're fine. The facial artery itself is 1.5 centimeters outside the commissure over here. It's sitting right about over here. It's almost consistent in when it's finding itself right here. That's where we look for it when we're doing our surgeries and stuff. So it's about 1.5 centimeters out over here that it does that, and I'm above that as well because it's deep.
So we're going to wrap up in the next 5 minutes, so let's open this up for questions.
Would you do anything with that chin?
Yes, please do something with that chin.
Yeah.
Let's take a look. Give me a little smile. Good girl. Okay. Let's do the other side too, please. That's a great little technique to give them support on the bottom part of the face. But it's a little tricky in her because of the Sculptra issue, but that's all right. We'll bend another cannula or two, right?
Yeah, facelift, Sculptra.
Yeah. You've had a facelift too?
I've had a facelift too.
Oh, God. Anything else? Let me ask. And you had silicone in your lips? We don't want to even go there, I think. Okay, this is a challenging case. You had no silicone in here, did you?
No.
No, okay. Can I have a dry sponge, please? Okay.
Do you have a chin
I'll see.
implant?
No.
No. We'll find out all these things afterwards. I guess it's something to ask beforehand. I went right in through that little lentigo that she had over there.
What meds I'm on.
All right, we have another question from
I
the
don't want
audience.
to know because you're too beautiful anyways, but I didn't do the clamp on you, did I?
I had a question about, we talked about neck and mixing some Botox with some fillers and doing the neck area. Is there any pearls for décolleté area?
Stay out of the sun. I'd like to hear from some of the derms over here because you guys are good. Yeah. I mean, this seems to be mostly energy. I mean, for the polytherma, it's more of energy device things that come out of a box that are going to help us. The BBL now I found is much better than the IPL that we've used in the past. That's personally, but I'm not a derm. For lines?
So Mark Rubin, what are you using for the décolletage?
Right.
Yeah.
When you say diluted with that terrible D word, what are you talking? 20 to 1?
Yeah.
20 cc?
Speak in the mic, Mark.
Yeah, 20 to 1.
Yeah.
And they just get beat to hell, too, from the injection.
Right.
Well, not 20 to 1. I'm sorry, just 20 cc's.
20 cc's, I mean. 20
Yeah.
cc's reconstitution.
Into a bottle, yeah.
So what you do is put a couple of cc's of lidocaine and the rest is saline?
Correct.
Okay.
No,
or water?
Bacteriostatic water.
Bacteriostatic water, I meant? Right. So why don't you try throwing in a couple of units of toxin in on that too?
Yeah.
Yeah.
It does actually. You're right. The toxin does work.
It does work in that area, and you're going exactly in the same area. You want it in the subdermal plane. And I wonder what would happen to the results then.
Any other ideas? Anybody
Maybe the whole
room?
thing would blow up in your face. I would laugh.
Do a series and then do it every year.
Yeah.
Just 70-year-old chest.
So can you do the next one?
How old?
I'll be 70 in 6
What are you talking about? Get this cannula out of the face. Are you serious?
In that blend of
not
miso
right.
for the chest, if you were to add Botox, what would you suggest would be a good dose?
I'm sorry?
How much Botox would you add to the miso for the décolleté? Just on your guesstimate.
I don't know. If I was to do micro Botox over there, which is the way that Waffles does that, he mixes up about 20 units and he puts it into about 4 or 5 cc's and just blasts the whole area with little micro Botox. So whatever I would use for that, 20 units goes into the Sculptra. I can't believe I'm saying this. What are you guys pulling out of me? I've never done it before, but Mark is going to do it and publish it.
So Waffles does this micro technique for years on the neck and the décolletage area as well. With you can look up his article. He just published this recently, and he uses about literally a half a centimeter apart for his injections, little blebs, and all through the neck and chest. Right, Arthur?
Yeah.
His article was in that article we did some publication in the Surgical Journal.
Yeah, he did it in the PRS.
April.
Yeah. Can I have a little bit of arnica gel, please?
For the whole.
What's that?
For the neck and chest.
For the neck? When I do it over here? Yeah. For the meso, what I do for the meso of the neck is I take out a syringe that has, I'm going to use probably about 30 units. I'm going to load it into a syringe that has, I use a 27 gauge cannula. Can you bring me one of them? I'll show them what the 27 gauge cannula looks like, the super long one. Yeah, it's this long.
50 millimeter.
It's a,
2 inch.
Yeah, it's a 2 inch. It's a 50 millimeter. And I do it like I'm doing liposuction. I just coat it all the way like this over here. And I use about 30 units with probably, in our case, we use Volbella, which you guys are getting. I'd use Resty Silk. It'd be beautiful. Blend the Resty Silk. Put in 1 cc of Resty Silk. It's a nice product to use over here. Get a little bit of hydration of the skin.
Yeah.
So use the Resty Silk. On top of the Resty Silk, I'll add in probably 4 cc's of saline. Okay? So you'll have a 1-to-4 blend, and then I put in my, the 20 units is just a small little amount. Mix it all up, make your champagne, go like this over here. I sometimes come in from the side and do it in a crosshatch way like that, and then sit back and watch the results.
Do you put in the cords as well?
No, I don't do that for the cords. For the cords, you can go after it individually, but you don't need to for the cords, really, if you do that much. I'm sitting here petting you like you're my pet.
I put so much. I had that problem when you said someone couldn't lift their head up.
You had that
I was trying to get rid of my platysmal band.
Yeah, no, that's.
Yeah, you got to be careful. Kent has a beautiful picture of a patient who was a little Munchausen type. She was really a plastic surgery junkie, and she kept on having injections gone continuously of 20-25 units into her crow's feet. And what ended up happening to her temporalis muscle is that disappeared. She was completely hollowed over there.
In fact, that's one of the big issues with those that treat headaches in the temporalis muscle is temporal fossa.
This isn't 70 years old.
Induced by Botox.
Go get your school books. You're on a recess break. Go get your school books. Look at the smile now. That's my smile. No black behind her teeth. Look at your smile over here. That's my girl. You like that? Yeah. Because we boosted it up a little bit. I find trying to hit that Risorius, if it's a patient with bells or something, is very difficult.
Yeah, no, it's pretty.
You did great. Thank you so much. I'd love to see some pictures on a follow-up of you. She's an amazing patient. I'd love to see some pictures on a follow-up with you. You're welcome. Please be careful. So let's answer some quick questions if you guys have about anything. Here's a yeah. Yeah, I think in a female I do a single injection in the midline because I like them to have a little bit more of a narrower chin. I would measure her from the upper lip coming down to the chin. That should be 1.618 of the distance over here. I think she was a little short, a little wide. I would put in some product, and when I do that, I'd lift the chin up and let it fall right down on top of the needle. They don't feel it. Keep your fingers over here like this to prevent the product from spreading where you don't want it to spread, and let it slowly fill. And she would probably need maybe, her skin wasn't that bad, I would probably still use a blended product, maybe 1 to 2 blend, and I would think that a cc of 1 to 2 blend, she'll need 0.5, 0.6 cc's to go ahead and do that chin. Remember, the chin is a 3D structure. 3D structure means height, width, and also projection. So look at the height of the chin sometimes, because people are going to be short-chinned over here. And when you do that, you want to run your product a little bit lower to do it over here to actually give them a little more chin length. In patients who have a little bit of accumulation of their submental skin over here, you see these little teeny little chiffon type of skin that sometimes they say, can you do anything about this? That's a hell of a work to do, just a facelift, to try to go ahead and get that out. There is no direct excision that we do that works well because the scars over there are terrible. You can zigzag them, you can do whatever you want. But look and see what's the projection of the patient's chin, because sometimes you can put a little bit of product into the chin and advance it just enough that it takes up that little bit of slack. Look for that when they put their chin down like this, you'll see it gather. Sometimes I run the product just in that area, especially with a little bit of toxin like we were talking about with a 27 gauge. Those patients, I try to cross-hatch and give them a little support here, and sometimes it works beautifully. So sometimes it doesn't, but I tell them that this is, witchcraft. And when I get the bone removed from my nose because I'm dancing around and I have a rattle at the same time when I'm doing this stuff, maybe it'll work. Yeah, all depends on E of face maps, the envelope. I get some women who are very thick-skinned as well, sebaceous. I have to use full-strength product. I get some men that have a lot thinner skin. Men, you see, the reason that we don't age better, we just get away with it. Guy gets lines, is distinguished. A woman gets lines, it's old. It's not fair. Sorry, guys. That's just the way it is. You take a look at a guy like Sean Connery, good-looking dude, all the way up till he was 70, 75, even though he had strong lines, because it was character lines in a man, but it's aging lines in a female. We get away with it because we have follicles in our upper lip that are acting like pylons going into the lip that maintain the structure. We shave every day, most of us do, that causes exfoliation, and so we're constantly turning over our skin cells. I mean, that's the idea behind light peels and the same type of issue. So we get away with a lot more stuff than you do, but here's the interesting thing. Here's the interesting thing I want you guys to think about, because you're asking me about men. In the cheeks, genetics are a huge factor in the cheeks. Cheek volume is what really maintains our aging gracefully when you think about it. Forget about the other issues of dyschromias and atrophic skin or whatever the story is, but just think in terms of facial shape. Look at a guy like Hugh Jackman. This dude is going to be good looking when he's 75. He has strong, strong, strong bones over here. He's got really strong malar prominence from his maxillary bones. And he has a nice V-line, and he's just a damn good-looking guy. And I haven't seen him change in 10 or 15 years. Take a look at his countryman, Russell Crowe. Russell was just a stunner when he was in Gladiator because his volume was maintained with fat. He had the cherubic cheeks that were out here, and he had that fat. But as Russell's aging or maturing, and he's still a nice-looking guy, but he's lost a lot of it, because everything is down here now. Hugh is staying up over there. That shows you with bone structure stuff that you can't, genetics, like Kent always says, winning the genetic lottery. We used to say, if you'll excuse the expression, you can't shine doo-doo. Right? So sometimes there's patients who just haven't won the genetic lottery. If you go on the internet, you'll see very derogatory things about pigs with lipstick, for example, is what they refer to. But when it comes into my practice, it's really understanding what are your capabilities and what are you able to do with the patient. When they have excellent bone structure, you're way ahead of the game. What are the difficult patients for me? The ones who are beautiful when they come in. They're demanding. They want a millimeter here, 2 millimeters there. They want to look better. They already look great. You have to hit your marks perfectly on them. Otherwise, you downgrade their beauty. Those are tough patients. Patient who comes in who's deflated like I am, anything you do to me is going to make me look better. Anything you do to somebody who's a grade 4 or grade 5 deflation, it's like doing a big hump on a nose. You're going to make them look better. So you have to understand what your limitations are. And it's what Kent is the best at, is getting into the psyche of the patient to understand why they're there at that particular time. Why are they seeking consultation now? And what are their expectations? Under promise, over deliver. That's what we do in plastic surgery. We're told that from day one. And that we have to do that with fillers too. Are there any more? We have to end it? We good for another 2 minutes? You want to answer some more questions? Kent, come up. We'll answer some questions. Yes, no? You want us to hang around? You can ask us hallway.
There's one in the back.
Is there one in the back?
What is your favorite filler to use for hands?
My favorite filler for hands? I was just talking about this with Mark before. What I use for filler for hands is could be Resti, it could be Ultra, whatever the story is. I use Voluma. We have a product called Volift, which is in between Volbella and Voluma, which is a beautiful product. Everything I use in the hands, I also blend, either 1:2 or 1:1, depending on what the thinness of the skin is over there. And it's a very easy technique. You make a little puncture at the top of the wrist. You put in your cannula. You fan it out. The cannula, as you're injecting antigrade, will push the veins out of the way. You see the veins sort of flop and they go out of the way. We're staying above the veins and we're staying above the tendons because that's what you're trying to camouflage. And then it's a lot of massage. And as I finish the massage, I put a gauze pad on it and the patient sits on it while they're lying back here like this. And they're sitting on their hand compressing it while I do the other hand. It leaves you no bruising. Some people, and I've seen Ghislaine Bélin, who's an excellent injector from Paris, she makes one big clump of stuff right at the very beginning and she just spreads it by massaging and massaging. And, to me, what you have to do is you have to get rid of the channels in between the tendons. Some people inject into the fingers. I do not. That's just my personal preference.
25 gauge cannula, 50 millimeter, 2-inch, 1 trocar hole.
Right.
Subdermal.
It works great. And you'll find that you have to repeat it maybe once or twice and then it sticks. Because that's the telltale sign, right? The hands. Beautiful face. And then you walk around with hands that, women are keeping them. We have pockets that we're allowed to put them in.
Yeah, that's much better.
The what?
The turned in upper lip.
The turned in upper lip. Every lip turns in after a while, even in men. I told you what happens is that your muscle of your upper lip, which is the orbicularis muscle, is shaped like a J, and it goes from a J to an I. And the lip lengthens. The ergotrid, or the white lip as we call it, the ergotrid starts to lengthen, and then what happens is the lip flips under, especially in women, because they don't have any structural support from the pylons of the hair follicles. As that lip flips under, you're in trouble. A really super thin lip, if you start to try to work on a super thin lip by putting product into the vermilion, you're going to make a mess. I have no lip. You can't inject my vermilion. What happens is that if you start to put product into the muscle, it'll hang there like a clanger on a bell, on the inside of a bell, and it's hanging below the teeth. There's nothing to project it forward, and you worsen the problem. So treatment of a thin lip in an older patient is actually into the white lip, not the red lip. You have to try to shorten this area. There's surgical things that can be done. Danny Cusuto talked about an injection technique. What we do with putting it into the piriform, he said that he can actually shorten the lip. But you watched on the patient that we just did the subdermal cannula that her lip flipped out. That's what you want to do. Flip out the lip more than anything else. Look on their old pictures. See if they have a philtral column that you can work with. Do the lower third of the philtral column and very little above it, because it doesn't look natural for a woman in her 60s or 70s to have two philtral columns going all the way up. Take a look at Catherine Deneuve and her pictures over the years. She's a beautiful woman. Her philtral columns were like almost touching each other when she was younger. She had the most beautifully sculpted upper lip. They're now about a half a centimeter apart to a centimeter apart. And whoever injected her lip put the product in at the Cupid's peak, and she looks this way when we're trying to make her look this way. So they should have gone a little bit more medial on the injection of the upper lip. I like to use Resti Silk, and you're going to get Volbella, which is another great product. Bellotero is another one that you can use. And I use it submucosally in the mature patient, because you're not looking for bulk in the mature patient. You're looking for contour. You're looking for pulpiness. You're looking for a rounded upper lip. By putting that product in submucosally, you just saw how I did it over here with the upper lip and the dermis. It's exactly the same technique. You can do it from the lateral vermilion, or you can do it from just above the vermilion. You'll pop in underneath the mucosa. Your cannula will slide with no resistance. And as you're actually putting in the product, you're going to see it spread from the white roll right down to the wet-dry junction, which is exactly where you want your product, and it just coats. I use a 50-50 blend of every product that I put in submucosally. You don't get bumps and lumps. You don't massage. You don't blast it. You don't mash it. You gently blend it like that, and you leave it. If you get an angioedematous reaction, which can occur very rarely, you hit them with one dose of 30 milligrams of prednisone, and it will settle it down very quickly. If you start to mash, if you start to melt, if you start to mold that stuff, the product doesn't like it. It gets a little bit of edema, and you start the cascade of the inflammatory cascade, and poof, out they go. You do both. You treat the upper and... I treat the upper to pull it out, and then I'll treat a little bit of that area over here. And I've seen guys like Wolfgang from Germany goes in from above and does the injections vertically like this to go ahead and to flip them out. It's a very interesting technique. It works. That's fine. It works for him. I think it's a little more painful, to be honest with you, and I'm big into keeping it as painless or as minimal discomfort as possible. Any other questions that you see, Bob? Because I'm blind as a bat up here.
I think that's it.
Wow, I can't believe that they stayed this
Hey,
late.
before we finish, I did want to get a thank you, a very big thank you to Deidre and Jennifer, our assistants back here who helped with Dr. Swift.
Boy, were they good.
Thanks, you guys. Thankless job, but nevertheless, very, very well done. All right. Remember, people don't buy products, right? They buy emotion. They buy identity. They buy experience. How's your experience so far? I need a better answer to that. How's your experience so far? Excellent, excellent. Jeff, you look really good, by the way.